A very good afternoon, everyone. My patient is a 11-year-old male with bilateral progressive Genu Valgum deformity of distal femur in origin, with right-sided standing tibiofemoral angle of 30 degrees and standing left tibiofemoral angle of 20 degrees, with rotational component in the tibia with normal range of motion, most probably due to some metabolic bone disease. Currently concerned with cosmesis, difficulty in walking, squatting, and climbing upstairs and downstairs, and easy fatigability on activity.
Okay. So on basis of history, what would be your differential diagnosis?
Also, based on history, my first DD would be vitamin D deficiency, sir.
Tell us your positive findings. This is a short case, so give us your positive findings. Upper limb problem, I think gait should be the first thing. If it's an upper limb thing, I can understand. Or the child or the patient who has a painful condition, you really patient not walking, then fine. To me, gait is one of the most important things that should be mentioned right off.
Yes.
Yeah. The other thing is that if you have children who have shorts or something, it's always good to get them stripped down decently so that you can see, because with these long pants and all, you'll miss a lot of things. Is he got an underwear or shorts inside?
Yes, yes, he is.
Then ideally they should remove it, because of course you don't want to make any patient embarrassed, but we must strip them decently enough so that you can check what you're looking for. So looking through clothes is one of the worst ways to examine children. No? Or for that matter, even adults. So anyone, if you're examining, whatever part you're examining should be adequately exposed. You don't want to jeopardize, obviously. See, wearing shorts, there's no reason why we are struggling along with long pants and then you're not able to find so many things which are supposed to be seen.
Yeah,
so here's a bipedal unassisted outgoing gait, sir, with both the knees rubbing against each other and with widely spaced ankle. Right, so
what is the cause of outgoing gait?
So it could be, sir. Sir, I'll first draw a line from ASIS to the center of the patella, and then from center of the patella, I draw a line from the center of patella to the intermalleolar line on the ankle, sir, and then the angle which these two lines make is the tibiofemoral angle, sir.
So why in supine and standing? Why want to waste your efforts at double?
Yes, sir. If a child has a high patent score, it can increase on standing, sir. And if the child has ligamentous laxity in the knees also, sir, it can increase on standing.
So how do you measure the tibiofemoral angle here? Measure this and show us. How much is the tibiofemoral angle here?
Sir, I'll
come this side. Come this
the
side.
knees together, sir. I'll make both the knees touch each other, and then we'll make the patella face upwards. And then in this position, I have marked the ASI, sir, and the center of the patella and the center of the intermalleolar line, sir. So I'll draw these lines and calculate the angle.
But so I think it's important that you must keep the patella facing up,
yes,
in the anatomical position before you do those measurements, not an external or internal rotation. Yes. But I think we never gave you a chance to describe your positive findings. So I think let us give you that chance first. Tell us all your positive findings, and then we'll come back again if there are any questions.
Sir, his foot progression angle is also increased. Sir, it is 25 degrees bilaterally.
Tell us all your positive findings.
Yes, sir. So from starting, sir.
Yeah.
Sir, he has a high BMI of 26.6, sir. He has tenor staging 1. Sir, on inspection in standing, sir, he has externally rotated feet on both the sides, sir. Sir, in the gait, he has outgoing gait. And sir, he has increased thigh foot angle and foot progression angle bilaterally. And sir, he has increased the tibiofemoral angle on both the sides, which increases further on standing as compared to supine, sir. And his intermalleolar distance is 22 centimeter on standing, and in supine it is 16 centimeters, sir. And his Witten score is 4. Yes,
on standing and supine.
Yes, ma'am.
So how does that, how do you explain that?
Patient has varus and valgus stress test positive on both the sides. Sorry, sir.
Increase on standing.
Increase some standing, so the intermediate distance.
Okay.
Yes, sir. Sir, I'll first flex the knees in 30 degrees of flexion, sir, and then I'll do the valgus stress test first, where I'll see the opening of the medial joint space, sir.
Anything else on examination? What else have you
I'm not
examined?
seeing that opening up so much because we are not convinced. Because Dr. Shrestha brought up a correct point. You're saying there's so much of difference between standing and supine intermalleolar distance, which obviously means laxity then. But you're not able to demonstrate that. Show me the laxity.
Why are you flexing at 30 degrees? Keep it in extension. Now, when he's standing, is it in flexion or extension his knee?
It's in extension.
Oh, so you have to test it in extension.
Yeah. Yeah, but it's not so much to explain so much of difference in your intermalleolar distance. Okay. Anything else that you want to mention, or you're done with your positive findings?
Anything which he has missed should have been mentioned. Patella, why is it important? You mentioned that he has difficulty in climbing up the stairs. What is the cause of that?
Sir, it can mean, sir, that the patient has some patellofemoral pathology, sir. Patellofemoral
Or
joint pathology.
not necessarily pathology, but the extensor mechanism and dysfunction
Yes, sir.
because of valgus.
Yes,
How
sir.
do you measure how do you measure the efficiency of extensor mechanism, quadriceps mechanism?
Sir, I'll measure the Q angle, sir.
How do you measure that?
Sir, I'll draw a line from the ASIs to the center of patella, and then from the center of patella.
What is the
to
normal
to
Q
the-
angle?
Sir, sir, in males it is 8 to 12, sir. In females it is 15 to 17 degrees.
How much is the Q angle here?
Sir, Q angle on standing is 30 on the right side, sir, and 25 on the left side.
So Q angle is one thing, but also patella maltracking in a Genu Valgum is well
Yes, sir.
known.
So how will you test for that?
Sir, I'll look for the J sign first, sir. J sign first. Sir, I'll ask the patient to sit with legs hanging at the edge of the table, and then I'll ask him to extend his knee, sir. So at the end of the extension, his patella should move.
What are the
laterally,
tests?
For
What are the
sir, I'll do active patellar tracking, sir. With the patient supine and the knees extended, sir, I'll ask him to contract his quadriceps. If while doing that his patella goes upwards and laterally, then that's a positive.
what is apprehension, sir?
Sir, with the knees flexed in 20 to 30 degrees of flexion, sir, I'll push the patella. I'll try to subluxate it laterally, and if patient is in pain and stops me, then that's a positive patella apprehension test, sir. And all these things are negative in these patients.
But
Anything
that you
else?
didn't mention. You skipped out the patella completely from your examination. That's an important lacuna in your clinical findings. Yeah.
Anything else? And shall we go on to yeah? What will you do next? What is your diagnosis now? Short case diagnosis.
Yes, sir. Sir, my patient is a 11-year-old male with bilateral progressive Genu Valgum deformity of distal femur in origin with right-sided standing tibiofemoral angle of 30 and left-sided standing tibiofemoral angle of 20, sir, with rotational component in the tibia and normal range of motion at the knee. Most probably due to metabolic bone disease, currently concerned with cosmesis, a difficulty in walking, climbing, and squatting, sir, and easy fatiguity on activity.
Did you mention it's asymmetric between the two sides? That it is
Yes, sir.
more on one side, less on the other?
Yes, sir. It's the same
In-
on both the sides, sir.
the same
Yes,
on
sir.
both sides.
No linear discrepancies there on both sides.
No, I'm talking of the severity of the Genu Valgum. Is it symmetrically same?
No, sir. It is asymmetric, sir.
Yeah, so I don't think you mentioned that. Huh? So how much is it on one side? How much is it on the other side?
So the length of the sir,
No,
femur is-
the extent of the valgus.
Okay, sir.
The severity of the
right
valgus.
side, it is 30 degrees, sir, and on the left side it is 20 degrees.
Okay, what is the differential diagnosis? Bilateral Genu Valgum in a 11-year-old child. What is the differential diagnosis?
Sir, it could be due to some metabolic bone disease, sir.
Like?
Or it could be
Like?
syndrome. Yes, sir.
Like what?
So you said rickets is one. We're asking etiology of the Genu Valgum. There's no doubt there's a Genu Valgum. So we're not doubting that. We're asking the etiology. So what are the conditions which cause a Genu Valgum?
Yes, sir.
One you said was rickets.
Yes, yes, sir.
Fine.
First is the rickets, sir. And then, sir, the most common cause is idiopathic, sir. And sir, then bilateral Genu Valgum can also occur in epiphyseal dysplasia, sir. And sir, it can also occur in conditions like osteogenesis imperfecta and Paget's disease, sir. Bilateral pathological Genu Valgum.
What else?
And sir, in the age, sir, up to the age of 8 years, it can be physiological also.
Suppose there is a history that there is bilateral Genu Valgum and the child has 6 digits. Sorry, 11 digits, 6 digits on either hand.
Sir, it's called, sir, too many toe signs, sir. Actually, the patient.
No.
Nothing, that's all.
In the hand.
Yes, sir. Sir, actually, it's a sign of skeletal dysplasia, sir.
Which one? Anyone knows? You're not expected to know, but
it's called polydactyly.
Chondroectodermal dysplasia, or Ellis von Creveld syndrome.
So there are so many syndromic causes. There are so many other metabolic causes. So I don't think you can only say, so rickets with all its different variants. So nutritional is only one. The renal rickets and all other types of rickets, hypophosphatemic rickets, all of them come under the rickets group. That's one group. Then you have all the dysplasias.
Yes, sir.
And most common will be metaphyseal chondrodysplasia as a cause of Genu Valgum, as compared to epiphyseal dysplasia.
Yeah.
What
Then
will you do?
Mucopolysaccharidosis, morchios is a very common cause of Genu Valgum. So you must have a list of at least 7 to 8 common conditions which can cause a Genu Valgum. Okay?
It will be an exam case, full question.
All right.
Yes, sir.
Next, what will you do for the child?
Sir, I would like to get one scanogram done, sir, from hip to ankle, sir, with the patella facing anteriorly. As a scanogram, sir, showing both the lower limbs from hip to the ankle joint, sir. So the mechanical axis on the right side seems to be deviated in the valgus Steven zone, sir. And so on the left-sided tibia, sir, it shows a slightly malunited tibia in slight varus, sir, which is giving the appearance that the mechanical axis is not shifted. There is slight varus angulation at the fracture side in the left tibia.
Is this a good scanogram? Do you think this is
No,
a...
sir, it should be
What's the
squared,
problem?
sir. It should be squared first.
Okay.
And,
Are the patellas centered?
yes, sir. It is in the center, but the right one could be. Sir. The left patella is in the center. The right one
How do you know whether the knee position is proper? What do you look at?
So I look at the joint line, so it should be parallel to the ground, so that both the knee and the ankle joint line should
Why,
be
if you have
parallel to
a...
the ground, sir.
That won't be, no? In fact, if it's a varus or valgus,
yeah.
the purpose of taking the X-ray is that you can be sure that the joint line won't be parallel. Because it's a valgus or a varus. So how will you know that that was the right way that it's been done? So when you write a prescription for a, say, first of all, you should avoid using the word scanogram, because we know that right is not called a scanogram. A scanogram is a very different type of X-ray where you take 3 shoots of the hip, the knee, and the ankle with a radio opaque marker through low limb length discrepancies. It was meant for that. It can be supine also. It doesn't have to be standing. What we're asking for is something very different. So in true sense, it's not really a scanogram. Scanogram is 3 shoots, hip, knee, ankle, supine, with a metal marker in between for limb length discrepancy. Here there will be a linear discrepancy, but it's going to be apparent. It's not a true linear discrepancy mostly in these children. It's just a valgus one side more than the other, so therefore one looks shorter, one looks longer than the other. What you're looking for?
Technical, I think word is the full length standing
Yeah, it's a
X-ray
full
of both
length
knees.
alignment X-ray. So it's a full length alignment X-ray from hip to knee, standing with patella facing forward. Whatever compensation are required for the shortening on one side for the pelvis to be neutral. So a little droop of the pelvis is acceptable, but if it's too much, obviously we don't want that. So these are the prescriptions that you must give your radiologist before you get the X-rays, so that they know to take it the right way, not where the foot is lying. Because we all know that these children have torsional problems. Every Genu and Valgum has a torsional problem. So we're not concerned where the foot lies, we're concerned where the patella facing forward, because that's the anatomical position of the lower limbs. So then based on that, so now you have this full length alignment X-ray in front of you. So what have you found from here?
So in this, the mechanical axis is shifted to the valgus zone on the right side, sir. And on the left side, sir, the tibia shows a slightly whereas a mal alignment, sir, which might be giving the appearance that the mechanical axis is not shifted, but it actually can be shifted, sir.
So once you have this X-ray, forget about what lines are drawn. Once you have this full length X-ray in front of you, what are you looking at? What are you looking for? What are the things that you're going to be doing now? So it's an unmarked X-ray. The first step is it what I wanted? Is it a standardized X-ray?
Yes, sir.
To me, it looks fairly okay. It's not the best. It can be better because I'm sure they've looked at the feet rather than the patella. And there's a little droop of the pelvis on the left side because they're not compensated for that deformity, that shortening which is there on the left side. Because it's apparent, it's less than the right, the deformity. But it's fairly okay. So based on that X-ray now, what are the next steps that you will employ?
So now I'll see if there is any deformity, sir. So first I'll draw a mechanical axis, sir, from the center of the femur head to the center of the ankle joint, sir. So if it is shifted, then that means that the child has some deformity, sir. So now in this case, on the right side, the mechanical axis has been shifted to the valgus zone, sir, which is more than the 8 mm distance from the knee center. So this means the child has a valgus deformity on the right side, sir. Now,
Normally, what's the position of the mechanical axis with reference to the knee side?
Sir, it should be within 8 mm medial or lateral to the knee center, sir.
Sure.
Yes, sir.
Or
8 plus minus 7 mm, sir.
That's a lot. I don't think that's true at all.
Most slightly medial.
The mechanical axis ideally should be slightly medial to the center of the knee. If you look at the tibial eminence, it's not going to the center of the tibial eminence. It's slightly medial to the tibial eminence by, I think, 3 to 5 millimeters. I don't think it's 7 to 8 millimeters.
5 millimeter medial.
So it's 3 to 5 millimeters medial to the center of the knee. That's the normal mechanical axis of the limb, how it should be going. Anything beyond that, either this side or that side, is abnormal. So you're very obviously it's in valgus. So that's the first step. There's a malalignment, which is there on both sides, right more than the left.
Yes, sir.
Okay. And
So if your mechanical axis deviation is normal, would you stop there and say that there is no deformity? Like here on the left side, it looks normal. Would you stop now?
No, sir.
There is no MADs. That means there is no deformity. Is that it?
No, sir. I'll observe him for that side, sir.
no, we're not talking about observation. That was the next step. Will you
Yes, sir.
be happy with that side and say that's fine because MAD is fine?
No, sir. I'll draw a JLC, sir, joint line congruency angle line, sir, and then I'll calculate the LDFA and MPTA angles.
So you will still do that for the simple reason is that clinically, of course, if you have a mechanical axis which is going through the right way, we are fine. But you still want to know because sometimes you can have a valgus there and you can have a compensatory varus down, which causes an oblique joint line, which may not be acceptable beyond a certain point. So it's not important, as Dr. Sandeep is saying, that just because there's no MAD and the mechanical axis is going straight to where you want it, but obviously there's a clinical deformity, you still want to know that. Because there's a deformity which is compensating one for the other. The mechanical axis is straight, but we know that for the normal limb, what are the requirements? The center of the hip, knee, and the ankle should be collinear, and the joint lines should be parallel to each other and to the floor. That's the only way you'll sustain those limbs till you're 80 years of age. Because even if you have a mechanical axis which is straight, but you have an oblique joint line beyond a certain degree, that's not going to be good for your knees. Okay? Up and a varus down and they compensate for each other, but it's 10 or 15 degrees. You've landed with an oblique joint line, and that's not good. Okay? So your first step is you have found out that there is a mechanical axis deviation.
Yes, sir.
Then the next step is
Sir, then sir, I'll measure LDFA and MPT angle, sir. And sir, if and so the normal values are 87 plus minus 3, sir. So if any of this is not in the normal range, sir, means that bone is the source of the deformity for this valgus orientation of the knee, sir. And so then in that bone, I'll make the mechanical axis of the proximal and the distal part, sir. And at the point at which those axes meet, sir, it is a point of the center of the rotation of the angulation, sir. And if we make an osteotomy point at that point, then the deformity will be rectified without any translation, sir.
so when you look at always a mechanical axis deviation, the first question in the MAD test is there a mechanical axis deviation?
Yes, sir.
Then second is, where is that mechanical axis deviation? That's where we draw not just the LDF and PTA, but all the other angles as well. You also want to know the proximal femoral angle, you want to know the distal tibial angle, you want to know the joint congruence angle. Because if you're saying there's significant laxity between standing and supine, there's a joint congruence problems as well. And the laxity is also something that you must keep a note of. So all of these measures are there. And then how much is it? So is there a deviation? Where is that deviation? And how much is that deviation at all the different levels? Then you're in a position to answer what's our treatment. So this is all the part of the mechanical axis test, the MAD test. So what do you do for this child? What do you do for this child?
From the knee X-ray, you say it's a metabolic, most likely to be metabolic origin. Any signs, radiological signs of?
So I see no signs of splaying, fraying, or sagarkapi, sir.
So what is the diagnosis then?
Sir?
But I'm seeing some white lines in that physis, no, on both proximal tibia and the distal
What are those
femur.
white lines?
Up. Okay. But there are generally multiple lines. Here I'm seeing the physis itself looks whitened out. So sometimes if you have overdose of vitamin D, hypervitaminosis, it's very common. Lots of children sometimes just get vitamin D for donkey's cycles. Then that itself can cause a problem. That itself can cause hypervitaminosis. I don't know, maybe I'm wrong, but sitting from here, it looks a bit dense to me. The
Sclerosis
physis.
has three important differential diagnoses. One is, of course, healing rickets.
Yes, sir.
Second is scurvy.
Scurvy, sir.
And third is radiation. So these three things can give rise to that density.
So when you ask for an X-ray prescription also, you've got these small X-rays, which I don't mind.
Yes, sir.
Okay, because sometimes on those big long X-rays, you cannot see local pathology. So sometimes in addition to that full length alignment view X-ray, there's no harm asking for an X-ray of the knee, AP and lateral view. But only asking for this is a horrible thing. Okay, because we know that there's a deformity, we know we want to correct that, or we should be correcting that. So an alignment view X-ray is obviously crucial. But having these small X-rays is also good because that helps you to find or localize the pathology sometimes.
What other investigations?
Sir, I would like to do metabolic workup, sir, like serum calcium, phosphate, ALP, sir, and renal function test also. I would like to do in this case, sir.
Not vitamin D levels.
Yes, sir, I would like to do vitamin D levels also, sir. 25 hydroxy.
Do you have
levels, sir.
investigations? Okay, so I'm seeing everything is normal. Vitamin D levels are 25. Alkaline phosphatate is normal.
Yes, sir.
Calcium, phosphorus, all are normal. What will do next?
So then, sir, keeping in mind his age and the skeletal maturity left, sir, I counsel his parents about the diagnosis.
How do you know what is the skeletal maturity like? How much of growth does he have left?
Sir, he is at 10 years one stage, sir. And then
Yeah.
I would also would like to look for his elbow X-ray, sir. If it's closed, sir, then I will go
Do you have elbow?
for procedures like
Elbow
So
X-ray.
you don't have an elbow X-ray. Looking at this X-ray, there are so many ways you can look at even from
Yes,
this,
yes.
you know.
it's actually
So you have
partially true,
Oxford,
sir.
you have the Oxford score as well. So you already have an X-ray of the pelvis in front of you. So why would you not use that? The elbow is fine because the elbow is a little better. The soft grain method helps you to focus a little more on the skeletal maturity. But even from here, you can at least say, because you have a pelvis in front of you, you can use Oxford bone age. You can use the research sign.
Research sign, sir, yes, sir. I can look for
Is the research sign a good
So
indication
it
of
is-
skeletal maturity?
Yes, sir. It is a sign
For
of
the
skeletal
spine.
maturity, sir.
Not for the limbs.
Okay.
Why? So you see a lot of spine surgeons use the research sign, but pediatric orthopedic surgeons very rarely use the research sign because the research sign comes in much later. Okay, we know that the lower limbs grow first and they fuse first, and then the spine grows later. So whereas the research sign is very useful for spine surgeons to know the spine maturity, For us, it is a very poor sign because the research sign comes in much later after the limbs already closed. So what's another sign to make out?
Pediatric orthopedics are already risen. Spinal surgeons take little more time.
So what other ways can you make out of skeletal maturity from this X-ray? So the research is not a good sign for us for the lower limb. So what else do we have?
I look for tri-radiate cartilage and the
Good.
distal
Excellent.
So the tri-radiate cartilage is a very important sign for skeletal maturity of the lower limb. So if you see a closed tri-radiate cartilage, you know that the limbs are almost finished their growth. But that's either
And
on or
trochanteric
off.
fusion.
Either it's there or it's not there. But doesn't help us to fine tune. That is why the elbow X-ray is better, because the elbow X-ray in the 2 years of growth, it goes through certain changes which help us to predict that do we have 2 years, 1.5, 1 year, 6 months, or no growth left. Whereas with the tri-radiate cartilage, it's either on or off. It's either open or it's closed. I don't think there's a way that looking at the tri-radiate cartilage, you can decide how much of growth is still remaining. So that's why it's a less useful sign to us. If it's closed, we know for sure there's no growth. If it's open, we don't know how much growth is there, which the elbow X-ray tells us. So I think whenever you're doing anything or you're thinking in terms of growth modulation, an elbow X-ray is important because the Sauvignon method helps you that pubertal growth age and the pubertal growth spurt to identify using the elbow epiphysis and apophysis.
Suppose you take an elbow X-ray and it shows that olecranon apophysis has ossified and it's still open. What will you do?
So then I would like to go for growth modulation surgery, sir. Like hemi-epiphysis.
Why not observation, physiotherapy, observation, bracing? Very good methods.
Much more, sir. So it is likely to progress more.
Till what age are these methods likely to succeed? Till what? Suppose this was a 7-year-old child with Genu Valgum deformity. What would you do for the child?
So up to 10 years, I could have waited, sir, but now he.
Why can you wait till 10? What happens? What happens before 10 years age and after 10 years age?
So we just talked of bone age. Okay, so we remember that chronological age has got nothing to do with us at all. We as orthopedic surgeons have zero interest in chronological age, especially around puberty time, because there's a huge mismatch. So for us, age of chronology is least important. A 10-year-old girl can be skeletally mature. A 10-year-old boy can have 6 years of growth remaining. So just gender itself is there. And plus 2 girls, you can have one girl who's got a completely open physis and you have one girl who's completely shut. So the age is the most useless factor for us. And that's the reason why as orthopedic surgeons, we talk of bone age, and bone age, especially around puberty time. All right. So please don't ever mention chronology of the child when it comes to decision making around puberty. It's always bone age. Okay.
So what are prerequisites for growth modulation?
So there should be some skeletal maturity left, sir.
How much?
How much?
2 months, 6 months?
At least.
At least how much? 2
Oh,
years, 2 years. At least minimum 2 years.
How does it depend? It depends also on the degree of the deformity. So if you have a deformity which is 30 degrees, maybe 2 years may not be enough. If it is 60 degrees, definitely not. If it is 5 or 10 degrees, yes. So it depends on the severity of the deformity and it depends on how much of growth is remaining.
And it
So
also
for that, we
depends
need
on
to
the
know.
diagnosis. If it's a metabolic, the capacity of growth plate to grow is normal. But if you're dealing with skeletal dysplasia, they are slow to grow and they require longer time to correct the same deformity.
Correct. So the decision depends, right, on the degree of the deformity or the extent of the deformity, the amount of growth left, and the etiology of the condition. All of 3 makes a difference. All right. So how do you decide that? Whether that's enough or not. Now, suppose she's got a 30-degree deformity and she's got, say, 1 year of growth remaining. How much of change can you make with a growth modulation, and how do you decide whether you go to femur, tibia, or both?
So on the side of femur, sir, the rate of correction should be around 0.7 degrees per year, sir.
Per year?
Per month, sir, per month.
Okay. Because if it's per year, then we're waiting 10 years for a deformity to correct. And with the tibia, proximal tibia? Yeah, this is a little higher level question, doesn't matter much, but at least, in the femur, approximately about 0.8 per month, in the tibia, about 0.4 per month. So that's half of the distal femur because this femur grows the fastest, and together 1.2. So if you've got a 12-degree deformity, that's how you can prognosticate to the parents and what you can also make a decision. If it's a 12-degree deformity, you know, about 1 year of growth is sufficient, because if you do both the femur and the tibia, if you do only the femur, of course, obviously, wherever the deformity lies, you want to correct it there. If there's no tibial deformity, you don't want to put a tibial growth modulation, but that's at some time you can cheat. So if you find the child who got very limited growth left and you say just 1 year, and there's like 8 degrees in the femur and 3 degrees in the tibia, or nothing in the tibia, I might still do both, because that helps me to get my correction quicker in the short time that we have for skeletal maturity. So a little bit of cheating here and there is fine, but obviously the first thing is that wherever the deformity, you want to put the growth modulation there. If she has got no tibial deformity, you have no right putting a tibial growth plate.
So what method of hemi-epiphysodesis you want to choose?
Sir, I'll use a 8 plate with screws. Sir, with
Why not
screws.
permanent hemi-epiphysodesis? Just stop the growth, no?
No, sir, he can still grow, sir. He is still.
What are the
some
disadvantages of a permanent
elbow.
epiphysodesis?
Sir, it prevents the limb length discrepancy, sir. Permanent growth arrest by hemiepiphysodesis. It can prevent limb length discrepancy.
Good. I think he's presented well also. I think a round of applause. You have missed out very few things. Even she's clapping for you.